Good afternoon. I'm Beth Scholand, and I think it's not too long before lunch, so I hope you can hang in there. I've been tasked with speaking to you about the pharmacological therapies for idiopathic pulmonary fibrosis, so I won't be covering some of the data about treatment for non-IPF that you just heard about. So let's see here. So I think we'll try to cover 4 and then actually 5 quick learning objectives. One, to review and discuss what we know about IPF-specific therapies. And then I want to spend a little time talking about considerations we have in treatment, because I think in real life that becomes a lot of what we do in clinic. Although we understand these therapies are effective, actually considering and who we use them in and how we use them is really a dominant part of what we do. Talk a little bit about comorbidity, realizing that other speakers will be covering these topics as well. I want to cover acute exacerbations and what we're learning about treatment of these, because I think this is oftentimes one of the most scary things we deal with. And finally, I'll finish with a quick synopsis of what might be coming down the pipeline. So it's no mystery or confusion to anyone in this room what IPF is. We all know this is a chronic progressive fibrosing disease that's associated with lots of bad things for our patients, including a quick time till death and progression to respiratory failure, and also worsening lung function and quality of life. And as Dr. Kropsky said, you know, this heterogeneity in what we see is really ripe for future research, looking at understanding the underpinnings of why patients progress differently, but it's not something we know how to manage right now when we think about treating patients. And I think the other thing to remember is these bad quality of life issues, the dyspnea, fatigue, appetite loss, dry cough, et cetera, are things that we shouldn't neglect when we think about managing patients with IPF. So although I'll focus primarily on pharmacotherapy of IPF, I think it's important to remember that it's a multimodality treatment and it's a comprehensive therapy. And we have to think about supporting our patients, making sure they understand what our follow-up plan is, with nutrition, palliative care, availing them of support groups and appropriate resources such as the PFF to help them become their own self-advocate and manage their disease. We have to think about the common comorbidities that they deal with and make sure these are being managed by either ourselves or our colleagues, making sure that we're taking care of basic healthcare maintenance such as smoking cessation, weight management, and helping them understand the benefits of oxygen or pulmonary rehab. And then educating them on the disease itself and what they can expect as much as we know, thinking about lung transplant evaluation when and where it's appropriate for our patients, and then making sure they have availability of research clinical trials. So what do we know about IPF pharmacotherapy? We've come a long way, and Dr. Ragu gave us a nice talk about guidelines, so I don't have to, go into all the differences between strong and conditional recommendations, but based on prior clinical trials that we've done, we now know that the use of warfarin or prednisone, azathioprine, NAC, ambrisentan, and imatinib are not of therapeutic benefits. So we have strong recommendations about using any of these agents in the treatment of IPF. And what we do know is effective, and we have a conditional recommendation for, are pirfenidone and nintedanib. And I'm going to spend a little time going through the data that many of you probably know, but just to be sure that we're all on the same page about why we think these therapies are effective and why we use them. So 2 clinical trials were done in tandem, or at least in the same time frame, and published at the same time on pirfenidone and nintedanib. Now, pirfenidone is a small non-peptide molecule, and it inhibits the release of pro-inflammatory cytokines, it attenuates fibroblast proliferation, inhibits release of TGF-beta1, and inhibits collagen synthesis. So one mechanism, very different than the mechanism in nintedanib, which is a tyrosine kinase inhibitor, a triple inhibitor, with anti-angiogenic, tumor, and anti-fibrotic effects. So there were 2 trials, and I'll go through these. Many of you may have seen this before, so I apologize if it's repetition. But the ASCEND trials done with pirfenidone was a 555-patient study that it went on for 52 weeks with patients that had IPF confirmed and had mild to moderate disease as measured by their FVC and DLCO. Importantly, they did not have obstructive disease, and they were able to manage a 6-minute walk test. And patients were randomized to pirfenidone versus placebo, and the endpoints that were measured included a composite endpoint of change in FVC or death, and secondary endpoints included 6-minute walk tests, progression-free survival, dyspnea, and death. And this, as we all know, because we're using these agents, this was a positive study. And what we learned was that both use of pirfenidone resulted in a 48% relative reduction in 10% decline of FVC or death. The drug is associated with some side effects that we manage in our clinic. These side effects were typically mild to moderate in severity, and oftentimes reversible or certainly modifiable if we counsel our patients and help them with some ways to help or to modify the symptoms. The primary adverse events I have circled here that we deal with are nausea, rash, dyspepsia, anorexia, and gastrointestinal reflux, and these were statistically more common in patients that were on therapy. Nintedanib was a similar trial that was done around the same time. Very similar appearing patient inclusion criteria, including an age of greater than 40, had to have IPF, but it had to be a relatively new diagnosis and under 5 years. Again, mild to moderate disease with an FVC 50% predicted or above, and DLCO in the mild to moderate range, and a high-resolution CT scan within the last year to verify the diagnosis of IPF. And this study included 1,066 patients and randomized nintedanib versus placebo, with the primary endpoint, again, being a change in the FVC. And this study, again, was positive, showing a relative decrease of about 50% in the change of the FVC, and the rate of decline in the FVC. Again, adverse events were present, and these were slightly different than what we saw in the pirfenidone trial, with diarrhea, nausea, vomiting, and weight loss being the most common and the most statistically significant. So based on these two positive trials, we now have the availability of using either one of these. They were both approved by the FDA on October 15th, 2014, so we've had experience now for about 5 years using these in the clinical setting. To compare and contrast a little bit of what we tell patients about these drugs, both drugs require liver function monitoring about every month for the first 6 months, and then followed by that by about every 3 months following that. Pirfenidone is an 801 milligram drug taken 3 times a day. You initially can start out with 3 267 milligram tablets, and if patients tolerate it well, there is an 801 available. We titrate the drug and at time of initiation, starting first with 1 capsule and moving up to ultimately 3 capsules daily. When patients do experience adverse reactions, we can modify these by reducing the dosage, interrupting the dosage, or discontinuing it entirely. We also like to recommend that they take this with food and help manage that, so patients understand that this should be taken with a relative large amount of food so that it can reduce those side effects. Nintedanib, again, liver function monitoring. This is a different dosing regimen, a 2-time-a-day regimen. Again, take the medication with food and approximately 12 hours apart. Again, we can manage the adverse reactions by talking to the patients about taking it with food, sometimes reducing the dose, sometimes interrupting the dose, sometimes discontinuing it, and we can alter their titration schedule as well. So we know that these drugs reduce the rate of decline of FVC, but are we learning more about these drugs? And as we've had more time to follow the drug effects and pool data, we're beginning to see trends towards mortality. Now, pirfenidone, this study did not have a statistically significant change in mortality on all patients, but we do see this positive trend in favor of mortality reduction. So when you look at patients here that have an IPF-related mortality and are on pirfenidone, there is a statistically significant reduction in mortality over the 120 weeks that we followed these patients. And similarly, a treatment-emergent IPF-related mortality, so patients that were on drug had a stronger signal towards a mortality benefit. Nintedanib has similar type data showing a trend in the favor of mortality. So in all-cause mortality, it was not statistically significant, but patients that were on treatment did tend to see a improvement in mortality. Now notice this is only followed out to week 52, not quite as long as the pirfenidone data. And I think this take-home message to me is that we stand by and we watch this as we have more experience with the medications, we can see what the mortality data will be with these medications. This was an interesting study done retrospectively that looked at an Optum Labs database. So looking at a claims database and using codes for IPF, Dr. Limper and his colleagues followed patients retrospectively to see what had occurred. And both these drugs over 2 years of therapy in this claims database showed improved mortality. So the patients that were treated had a much better mortality rate in the 2 years than those that weren't. And what's interesting about this is the two antifibrotics were actually equally effective. So it did not matter which antifibrotic you were on, both of these did benefit mortality in this study. And also importantly, all-cause hospitalizations was reduced, again, similar for both drugs, but was seen consistently throughout the 2 years of this study. So this is some retrospective data that gives us more confirmation of what we think must be true, that these drugs are reducing mortality. What about combining the antifibrotics? Many people want to know whether if we put two of them together, would we do better? And the data is really early on this. What we've done so far is that there's been two studies with a small number of subjects who looked at the combination of these drugs. One patient would be stable on pirfenidone, then nintedanib was added, and the other was nintedanib plus or minus pirfenidone. And the endpoints were not to look for whether it was effective, but whether it was tolerated. So this endpoint looked to say who was able to complete the 24-week trial, and this one was to look primarily at whether there were GI side effects. And in this study, 73 of the 89 were able to complete the trial and in this one, most patients had some GI side effects, but we didn't see a significant difference when patients were on combined drugs. So I think this data suggests to us that at least it's safe and a reasonable consideration to move forward with efficacy studies of combining therapy. So what about decisions and treatment? So I've told you that we have two drugs that are effective in slowing progression and maybe even improving mortality. So how do we talk to patients about getting these drugs? Well, it turns out that there's a lot of diversity in our pulmonary community on how we do this. And this was a study that looked at maybe why we don't initiate therapy and what holds us back. And so common reasons that I think we all would experience, and we talk to patients and say, would you like to be on these drugs? And reasons we decide not to start therapy, patients on therapy have to do with their age or their frailty, also comorbidities, uncertainty about whether we understand the diagnosis. But where these are asterisks are telling us what is different between providers who routinely would start therapy within the first 4 months of diagnosis, so those of us that are ready to quickly pull the trigger, start the drug, believe in the efficacy, versus providers that are more frequently tend to wait to start therapy. So we look at the diversity of this group and say what is making people decide to wait versus those that are jumping right in. And the primary reasons that we tend to wait, those of us that tend to wait on starting therapy, have to do with the fact that we've judged the patient to be in good condition. They're asymptomatic, they have a good quality of life, we don't need to change anything right now. The other primary reason that we are different in how we start or don't start therapy is we judge a patient to have stable disease. So those that we think are stable, we may not want to start therapy. And the other reason that we say those that wait cite is that the patient made the choice. The patient said, I don't need to start this drug, I'm doing well in life. And when we queried the patients were really much more focused on preventing disease progression than avoiding medication side effects, suggesting we may have a disconnect in how we're educating our patients on whether or not this is going to result in decreased progression. And this study published this year suggests that maybe we should think again about the stable progressing patients, because we can see that on a 220-week open label extension of pirfenidone, that right away, very early in the course of treating patients with pirfenidone versus placebo, we see a separation in the curves. And patients that start pirfenidone early on in their stage have a slower rate of decline all the way out to 220 weeks starting right away. And we really can't regain that decline if we were to start therapy, say, up here somewhere in the middle. So early start of these medications may forestall progression of disease. So the other thing to think about when we're talking to patients about starting these therapies is that we're really sharing the decision with them. And so it's important that we set expectations and patients understand what they're getting into when they start these drugs. So we need to make sure patients understand that we're not going to be curing their disease, and we're not going to actually even make them necessarily feel better. And the starting on this therapy doesn't preclude the ability to be in clinical trials, so they can also partake in research if they want. There are some patients that probably aren't really appropriate for therapy, and this is a sort of a subjective decision, but patients that are very elderly, certainly patients that have very severe disease, it might be much more appropriate to do hospice than start a medication, particularly when they're not going to feel better. And patients with multiple comorbidities or complex medical regimens where we're going to compound side effects and potentially reduce their quality of life are people that we might consider not starting therapy on. But in all of these decisions we make, we want to make sure we're talking with the patient and they're agreeable to how our conclusion of whether this medication is appropriate or not, and that it becomes a shared decision. So let's touch base a little bit on comorbidities. Dr. Lancaster this morning says that she screens all her patients for GERD and considers therapy. I think we all do that. And she reviewed this data with you earlier that, oops, I keep doing that too. That about 90%, up to 90% of IPF patients may have GERD, and many of them are asymptomatic. And even further, when we treat patients with PPIs, we may or may not be adequately suppressing their acid, and we have to be aggressive about PPI therapy. This study that was published by Dr. Lee et al. In 2011 showed that in a retrospective manner, patients that were treated with PPIs had better survival than those that weren't. That consideration, this led us to think that treating patients with PPIs will have a positive effect on their disease progression. And this led to the 2015 clinical practice guidelines that said that patients have a conditional, and we all know what conditional is after this morning, recommendations for the use of anti-acid medications in patients with IPF and even asymptomatic GERD. So for quite some time, we all wanted to treat patients with PPI regardless of whether they had symptoms or not. What has boiled up in the literature since this time and even during this time is that we really don't have randomized control trials that recommend this, that support this recommendation. And when we look back post hoc at some of the clinical trials that have been done that included evaluations of patients that were or not on PPIs, there did not appear to actually be a benefit to the use of PPIs, and in fact a suggestion that patients had more exacerbations or infections related with the use of PPIs. So suffice it to say that there still remains strong debate about the exact role of PPIs and even the Nissen fundoplication in the treatment of GERD. And I think that it becomes an individual decision. Certainly patients with symptomatic GERD should be treated for their symptoms, but whether this is for all patients remains to be seen. Pulmonary hypertension, I will say with one line because Dr. Stephen Nathan will give you a discussion later on how we think about treating pulmonary hypertension in the setting of ILDs. But at the moment, there's no known benefit to therapy in all patients, and it's an ongoing subject of study. Now, oxygen is another thing that we all deal with very frequently, and per the ATS, ERS, JRS, ALT guidelines, clinical practice guidelines I cited earlier, this is a strongly recommended intervention. So it's strongly recommended that we consider oxygen in all patients who show desaturations. What do we know about oxygen? Well, we know that in studies that probably it does improve exercise capacity in an acute setting. So patients that are exercising and wearing oxygen will do better than patients that aren't. But it's not clear that really translates to improved physical activity throughout the course of the day. And there's no consistent evidence that it improves dyspnea, although it might improve exercise capacity, it doesn't necessarily improve dyspnea or quality of life for patients. And there certainly is no study that has definitely documented a survival benefit from long-term oxygen treatment. So I think, and there are actually some suggestions from quality of life studies that it is harder on patients. It decreases their quality of life having to manage oxygen. So I think although we have this strong recommendation for oxygen, this is another place where more research would be very helpful for us to understand what the place oxygen has and who is the most appropriate candidates for oxygen in patients with IPF. Now let's shift gears a little bit to acute exacerbations. This is that dreaded event that occurs in our patients, and it may occur, depending on the series you read, in 10 to 50% of patients per year, and it oftentimes results in respiratory failure and or death, and often in only a matter of days. So again, this graphic that shows the rate of decline in the disease progression, this patient that's having these stuttering and course with periods of stability followed by decline, these are representing some of those acute exacerbations that might be happening on our patients. And patients have, this diffuse ground glass in their CT scan. They have a sudden change in their pattern, and it happens relatively quickly. We understand some about acute exacerbations. We understand that some of these are triggered potentially by an infection, by a procedure, by aspiration, but there's certainly many events of acute exacerbation that are unexplained or idiopathic. When possible, we can treat the underlying cause, but oftentimes we are left with simply trying to manage the respiratory failure that's occurring with the patient. There are actually no proven effective therapies. There's no randomized trials that tell us that one drug is effective versus another one. Based on those same guidelines I keep referencing, our weak recommendation is that we use prednisone. The dosing of that is not entirely clear. We can do ranges from prednisone 1 mg per kg per day orally versus methylprednisolone 1 gram per day intravenously, followed by 3 days. There are tapers that we can use. The tapers are varied. And we can sometimes consider long-term weans, and exactly how long we wean is not also standardized, and steroid-sparing agents can be considered. We are noting that there's probably some impact from the antifibrotic therapies on the risk of exacerbation, but the data is still evolving there. And there's many experimental therapies that have been published in the literature in a series of case studies, and I want to focus for a minute on this last one, the Rituxan immunoglobulin plasma exchange therapy. So this is a small study that was done in Pittsburgh, Alabama, and showed in the end there was 18 patients screened. 7 were initially treated with an original regimen of therapeutic plasma exchange Rituxan, and then the regimen was subsequently augmented, so patients ended up getting 9 courses of therapeutic plasma exchange Rituxan and IVIG. And the data that's emerging is relatively exciting. So the controls are historic, and as we know, patients historically do not do well with acute exacerbations, but, oh my goodness. But when we treat these patients with the combination therapy, we see a trend towards improvement of survival with many of the trial subjects improving and going on to survive and showing a dramatic improvement in their oxygenation with this course of therapy and a dramatic improvement in their walk distance. So this early data has led to a multi-center NIH-supported trial looking at this regimen for acute exacerbation. So hopefully with more information and data, we'll have improved options for treating acute exacerbations. So therapies are evolving, and if you look at this graphic, we have many opportunities to intervene with pharmaceutical therapies and other mechanisms. So looking at a model for how IPF occurs, we can start with this injury that may occur on the alveolar epithelial space, and then the epithelium being injured, the mesenchyme remodeling, and also opportunities to intervene in the vascular space. And here's a variety of agents that might be considered in this regimen. Looking at this a different way, we can look at the IPF treatments we have currently and what are in process and understand where they might fit in this rubric. So thinking about the initial injury on the alveolar epithelial cells, we can think about, we just talked about whether anti-reflux therapy is helpful, treating sleep apnea that Dr. Lancaster talked about this morning, consideration of antibiotic therapy, either acutely or chronically, to change the microbiome and maybe alter the injury that's occurring at the alveolar epithelial cell level, are all potential therapies. Similarly, once that is injured, how can we modify that response? And how can we modify that inflammatory response to TGF-beta activation? Several agents in consideration. The drugs that we currently have available, the nintedanib and pirfenidone, occur right here with the myofibroblast proliferation and altering that regimen. And we have more agents in study looking at that. Once that repair is not being able to be mitigated, and we have this unrestrained fibrosis, agents that may interfere here. Tissue repair might occur through mesenchymal stem cells, and as I think you've heard several times, this is certainly not ready for prime time, but early studies are underway on this. And then managing patients holistically and symptom-based with palliative care, thinking about cough, thinking about dyspnea, et cetera, are all modalities we have. Some we can presently do, and some we're still learning about. And here's a smattering of clinical trials that certainly not all inclusive, but this is a rapidly evolving field, but clinical trials that are available for us to use. And you can see that many of them are focused on IPF. Some are focused on symptom control, such as this pulmonary rehab study that could be considered, and treatment of cough in patients. A variety of durations of studies, most patients looking at mild to moderate disease. But these are all evolving, and certainly this is slide's probably already outdated and will be continue to be outdated as time goes on. So much activity going on in this field. One way to keep track of this is certainly clinicaltrials.gov, and also the Pulmonary Fibrosis Foundation has a really nice page to help you find clinical trials that are available for your patients. So in summary, I think I wanted to impart with you some information that we do have active drugs that we use in IPF, and these are drugs that are effective in slowing decline, and we're learning more and more about how other ways that these drugs are effective. It takes a little bit of work, shared decision-making with your patients, and managing the side effects. Acute exacerbations remains a real problem for us, but I think now data is evolving that we may have different therapies for that, and clinical trials and additional therapies are on their way. So thank you.